Okay, so it looks like we're at 1:30. We'll go ahead and get started. I'm going to go ahead and, all right. So thanks everybody for taking the time this afternoon. I know it's the end of a busy day, so especially online. But I want to thank you for being here. We're going to be doing an hour together, and I will be presenting the least costly alternative, the true economic value provided when appropriate CRT is prescribed. So thanks for being here. My name is Catherine Sweeney. I am a physical therapist, a ATP, and an SMS. I have been a PT for over 30 years, the last 15 of which I worked as the lead clinical seating specialist at my local hospital system here in Portland, Oregon. I joined Permobile 2.5 years ago as a regional clinical education manager for the Pacific Northwest. And while I am an employee of Permobile, what brings me to this talk is my years of passion for advocacy. So I was really excited when the theme showing our value was this year's ISS conference theme when it was announced, as I am passionate about improving client access to CRT, and showing our value is a critical part of this in the US. So let's get started. The objectives for today's course are as follows. We're going to identify 2 barriers to obtaining medically appropriate DME and complex rehab equipment in the current model of equipment procurement in the US. We're going to look at specifying 3 frequent secondary medical complications related to inadequate equipment prescription or delayed equipment procurement for wheelchair users. And then we're also going to list 3 healthcare cost-saving benefits as a possible result of implementing a proactive CRT prescription approach. This is a roadmap to where we're going to go today, and we're going to break it down first with looking at what the difference is between CRT and DME for those that are budding seating specialists. We're going to look at the current CRT provision process specifically to the US. Then we're going to explore and kind of compare and contrast the economics of injuries that are occurring using our current reactive system in the US, which would be the repetitive stress injuries, pressure injuries, and falls being the 3 I plucked out. Then we're going to touch on healthcare economics and really talk about an exciting opportunity for us in the CRT world, summarize the work to be done, and then close it out and hopefully have some time for questions. So first of all, what is complex rehab technology, or CRT? What do we mean by that? And first off, I want to give a shout out to the VA and the University of Pittsburgh, who worked together to develop this important resource. Published most recently in 2018, the Clinical Limits of Use Tool, or CLOUT, for wheeled mobility devices. And this tool was developed, quote, in their own words, to support the VA to maximize the quality of service for veterans, while also ensuring that medical devices meet safety and performance expectations. And again, I want to highlight safety and performance expectations. So this is a federal government system that recognizes and took the time to really spell this out. And I think that being in our world of Medicare, another federal system, we can keep reflecting back into this belief that safety and performance is important and makes a difference. This is very easy to find on the web. If you just Google CLOUT and VA, this will come up. So looking at examples of what DME, or durable medical wheeled mobility device, are, we're not going to spend a ton of time here, assuming a lot of people that attend ISS are already on the same page. But these are, in my mind, to and from devices. None of these, in my mind, are categories of chairs that you would put underneath anybody that spends all day, every day in a wheelchair. And the CLOUT tool agrees with this for the most part. Starting at the far left, the standard K1 through 3 chairs are very heavy, oftentimes steel, very limited in sizes, and very limited in available modifications or just adjustments. The middle category, the K4, is, I think, a category that's worth discussion as an industry. I mean, it's definitely has its role, but again, these are limited in sizes. While it has a few more sizes available than the lower categories, a few more features available. Even the Clout tool points out that this is really not meant to be or intended to be a full day, all day, everyday device. Unfortunately, I think a lot of clinicians still view this as a device that is appropriate for post-CVA recovery or the geriatric population, because I think the misunderstanding is that the higher level chairs, which we'll cover in a minute, the K5s, are for your younger population or your spinal cord population. And this is kind of an outdated mode of looking at this equipment. So we're going to talk about that in a little bit and talk about the cost savings when you issue or prescribe a better chair for the all day, everyday client needs. Going into the power chairs, you've got your scooters, you've got your group 1 and 2 power chairs, and there is a role for these. These are great devices for folks, again, that are needing that to and from device, who may be struggling with pulmonary issues or cardiac issues or mild orthopedic issues, but don't spend all day, every day in that device. They may transfer out. So great devices when used appropriately across the plane here, but this is not CRT. Moving into the CRT category, we've got the ultralight manual wheelchairs on the far left. And these chairs are really the chairs that are intended and recognized as valuable for folks that spend all day, every day in their chair. This is why Medicare did not attach a diagnosis requirement to this category of chair. These are highly adjustable, highly configurable, made with very lightweight materials. And these are the types of chairs that we really need to be advocating for our full-time users who use manual devices. Also in the CRT category is your power assist devices, hub mounted, which is what you see here, the smart drive. The rear mounted is the smart drive, and then also the hub mounted, where the motors are on the wheels. These are devices that are excellent for a bridge between a power chair and a manual chair. And these are really appropriate devices for folks whose home cannot accept a power chair, whose lifestyle and ADL routines cannot be adapted to a power chair routine. So while these oftentimes are criticized as being more expensive than a group 2, you can advocate that these are more appropriate for that client's specific routines and needs. Tilt and space manual wheelchairs are CRT in, again, the level of adjustability and features offered. And then you've got your group 3, 4, and 5 power wheelchairs. And we're going to cover a little bit more about these devices coming up, but these are your power wheelchairs that are intended for all day, every day, offer adjustability, offer the modifiability that clients with complex needs need. These categories of power wheelchairs, specifically group 3, 4, and 5, are specific to a diagnosis, however. So you do have to have that discussion with your supplier about where your client fits. So now that we know what CRT is, let's talk about what CRT does. So CRT certainly improves the quality of life for its users. Clearly, a client who cannot reach overhead, users of wheelchairs sit quite a bit lower, and being able to reach items overhead that normally are out of reach by using a power seat elevator is a huge improvement for their quality of life. This is not convenience, this is function. That's just one example. CRT certainly promotes health, obviously with power wheelchair seating functions such as tilt, recline, and power stand. You can really help to assist in reducing the risk for those pressure injuries that we all worry about. Promotes participation. You can see multiple examples here. You have a surgeon who is using a standing power wheelchair to continue his job as a surgeon, access his clients. Participation such as obviously Stephen Hawking throughout his lifetime, progressively being able to participate in his profession to benefit all of us by using the options of CRT. And then Senator, I don't know if everybody's aware, this senator on the lower left-hand corner is a war veteran who lost her lower limbs, uses a prosthetic for transfers, uses a ultralight manual wheelchair, and she's a mother, she's a senator, and she's an excellent advocate for our field. So this is participation. And this kind of all comes together to reduce disablement. And disablement is kind of a term that not many people have heard. It really is a term that reflects the gap between the person's conditions and what the environment presents. So reducing disablement might be, for example, that seat elevator that allows that person to reach the elevator buttons in their building, or allows that person to function more independently at their job. So their spinal cord injury may not be as disabling as the barrier of those reaches. So CRT can really reduce disablement in the setting that they work or live. So now we're going to discuss the more common process used today when providing CRT interventions in the United States. And then we're going to compare and contrast these proactive and reactive approaches to CRT provision from a healthcare economics standpoint. And as we delve into the topic of wheelchair service provision, I want to highlight again, many folks have mentioned at this conference, but it's worthy of all the mentions it gets, the RESNA Wheelchair Service Provision Guide. Obviously, we've talked about this as an excellent resource, which summarizes the necessary steps when providing CRT interventions. And I plucked this quote out because I really think it's a nice summary of why this is so important. Because neglecting due diligence can be harmful, costly, and further promote disablement for consumers. So in my mind, due diligence includes not just looking at the MSRP direct cost comparisons, but asking for quality and durability data on the equipment that you're prescribing, and participating in advocacy to change how CRT is viewed by the funding sources. So to me, this is a very nicely, concisely written document that is an excellent roadmap for all of us. CRT devices in the United States require a specialized clinical evaluation and the involvement of an assistive technology professional, or ATP, to be involved to configure, fit, and train the client and or their team on the equipment use. So this is Medicare's requirement. And this is really an acknowledgement that this equipment is important, that this population has a higher risk for complications, and a team approach is needed. And I also want to highlight that many members of the CRT team have certifications and licensures that all include an ethical statement of participation. So we as stakeholders in this process pledged our own code of ethics throughout our professional organizations. And I think we need to remind our funding sources of this, because unfortunately the narrative sometimes is that secondary gain has outweighed the recommendation. So I just think we have to keep reminding and acting in that manner, of course. I also included the insurance team here. In this schematic, the insurance team is really important. I really think it's important for us to foster a healthy relationship with our insurance authorization teams, to be able to gain their trust and to be able to continue to educate, because clearly new technology comes out all the time. And oftentimes these authorization team members aren't given this new updated information as to how this is medically appropriate, how this is functionally beneficial, how this could save, be a cost savings benefit. So we just need to keep in touch. We need to make sure that they see our industry as a resource to help. And then when you do see overly restrictive authorization trends, we also need to advocate for change and take insurance providers to the mat when we see inappropriate barriers being thrown up. And as the RESNA Wheelchair Service Provision Guide emphasizes, best practice is client-centered. So ideally, that means the consumer or someone on their behalf advocates for equipment that will meet their needs. Unfortunately, what we see is oftentimes the reverse happens, that first funding is considered, we look at the face sheet is examined by somebody, and the discussion starts to shift on what they will qualify for just based on what past experience was. So then oftentimes clinicians and suppliers might have a bias based on either their personal comfort level with certain equipment. So they may start to kind of not even bring up devices that maybe they aren't as comfortable with, or they don't have as much information about. So unfortunately, the client tends to be the last in this conversation, but best practice is that the client remains at the center. I'm going to talk about a resource at the end that is an excellent resource to give out to your consumers. A couple of resources, but they're in the handouts tab right now. So please look at the alternative funding guide as well as the wheelchair handbook, because these are client-centered, these are consumer-centered. And our job is really to prescribe based on need, have the discussion on what coverage and see what happens on coverage, but also give them resources on other ways that they can fund that equipment so that we're not the barrier into that process. When we are the barrier, the result is a high rate of dissatisfaction and equipment abandonment, as found by Kittle et al. In 2002. And we've all seen that, I'm sure, in our practice. You prescribe a chair, they come back in their old chair when you have them come back for their next visit. So we have to stay involved. We have to remain in the process until it's right. Other barriers for obtaining appropriate CRT is what I touched on earlier, that some of the categories are based on diagnosis or qualifying. So the group 3 power mobility device being an example, or some of the seating and positioning codes that you need before qualifying for a pressure relieving surface. Insurance limitations, for example, Medicare, limiting mobility devices to needing them in home. Some Medicaids still use that in-home rule, even though they've been directed by CMS that that's not appropriate. If that's happening in your state, there are ways to reverse that, and I can help with that. We did that here in Oregon through a coalition that I helped co-found, but that's been a long-standing error by some Medicaids that you can change with the rules process. So the other thing I would say is that in general, the US still uses a reactive authorization criteria, and that is a big barrier. So we can't qualify them for power assist until they already have damage to their shoulders oftentimes, or their upper extremities, or pressure injuries, for example. This is the exciting part for me, and I keep hearing this during this conference, and I love that this is that the drum beat's getting louder. So there is a value-based opportunity that is emerging in the US that I think we all can kind of glom onto and see if we can advance CRT among this model. And this is called value-based healthcare, for those that are new to this concept. And when you look at the definition, or an easy simplified description, value-based healthcare is when providers are rewarded for helping patients improve their health, reduce the effects and incidence of chronic diseases, and live healthier lives in an evidence-based way. So it's moving away in certain areas, not all. This is not global in our US application yet, but in 5 main areas, they've moved away from fee-for-service, where providers were paid based on quantity, not quality, and they're moving towards a value-based service model. So I think this is very exciting. I'm going to cover a couple ways that we can possibly use this as our own drumbeat when we're meeting with national and state providers. So by certain aspects of looking at that value-based system, CMS, well, let me pause here before I go to that CMS piece of the 5 categories, but this benefits all stakeholders. So if you look at what value-based programs and that approach can do for consumers, it could lower personal cost. We'll cover that in a little bit, and provide better outcomes for the consumers. The providers could have a higher patient satisfaction coming in, as well as have better care efficacies. The payers have stronger cost controls and reduce risk. And then the suppliers have an opportunity to align their prices with patient outcomes. And then as a whole, society can have a reduced healthcare spending and overall better health. This is a slide, if you look at this graph, which the resources at the bottom there, this reflects kind of the slow evolutions towards value-based programs. There are 5 categories that were the original value-based programs. I'm not going to go into these in detail, but you can see them on that right-hand side of that graph. But what I really want to point out here is that home health value-based program is one of the programs that were one of the sites that were piloted across 9 states, and it was so successful in what they found that it's going to become part of the national model in 2022. So let me go ahead and touch on that specifically. The original rollout resulted in an average of 4.6% improvement in home health agencies' total performance and an average annual savings of $141 million to Medicare without evidence of adverse risks. So the evaluation of that original model and being so successful, they determined that they're going to go ahead and make this nationally a program that everybody is going to be used and measured by. So if you're a home health therapist out there, or if you're working with home health agency, CRT can really be a part of this solution. They're going to be looking for functional outcomes that reflect that their involvements are beneficial. Or their interventions, I should say, are beneficial. And this proactive approach has been used for a long time in other areas. For 20 years, we've talked about in the marketing of heart health that you should reduce your stress. This is in the media all the time. Go to the gym. Some insurances are paying for gym memberships, and it's because they are really finding economic value in these areas. So using a proactive approach, they're really looking at data. It's data-driven, evidence-based, it's not new. And the focus is on not just cost savings, but better care for individuals, better population health, and lower cost. So I think this is extremely exciting. And again, this is the areas in which the authorized programs were rolled out, and home health is kind of listed in that circled area. I do have a handout of these slides. If anybody wants, some of these resources are at the end of that handout. So I think this is a great opportunity for CRT. I do want to give a huge shout out. I'm not going to go into detail about this cost analysis instrument, but there is a great several articles written by Renzo Andrich. He is an Italian engineer and researcher, and he created the SIVA cost analysis instrument, or the SCAI, in response to a request from the Italian government in the Lombard region. And he was tasked with creating a system to identify the cost-benefit ratio of government-funded assistive technology, and looking and really trying to look at a broader lens of what the true costs are. So, in going basically beyond that purchase price. So what he did is they looked at, and I'm not going to again go into details, there's 4 worksheets entailed in this instrument. This instrument has not been implemented as a countrywide tool as yet, but it's really something for us to think about in this approach. So what he did, and when you go through the worksheets, you really look at the client's functional needs, medical needs, of course, but you look at their setting. You have to compare multiple devices on how that would impact that client's caregiver costs, that client's ability to work or not work, the impact on the family and who can work and not work, the cost to modify the setting in which they live, the cost of their transportation. So in short, it's a huge lens of really being able to measure what true cost society is paying for this device versus that. So it's really interesting. This is just one study in which the SCAI was used. And if you look at this graph, the y-axis lists the overall cost savings to the client. This was 79 clients involved in power wheelchair prescriptions between 2008 and 2013 in Italy. And if you look at the y-axis, that's the overall government savings and society as a whole. And the number along the top, along the x-axis, shows how many chairs were provided that fell in each cost savings range along that left side. And as you can see, starting from the top, 2 power wheelchairs were provided that generated an overall government and society cost savings between 170,000 and 190,000 euros. 3 power chairs were provided that saved between 130 and 140,000 euros. And the vast majority of the cases saved the government between around 10 to 50,000 euros each. And while 11 of those cases cost the government some money, that cost was between nothing, breaking even, and about 10,000 euros. So overall, this analysis shows that taking into consideration not only the purchase price, but also the cost of maintenance, how much home attendant services will be needed to utilize this technology, et cetera, can save a lot of money in the long run to the client and the public health insurance program and society as a whole. Okay, so I just want to take a look at my time here, make sure I'm not going to run too long. Let's do some cost comparisons of what we're currently spending using a reactive CRT prescription approach. We're going to look at repetitive stress injuries, pressure injuries, and falls. Beginning with repetitive stress injuries briefly, causes, incidents, what we're spending on surgical management, and then what would happen if we just looked at it from a proactive wheelchair configuration model. And while we're not going to have an in-depth discussion of each one of these common injuries, here's a quick review of the 3 most frequent upper extremity repetitive stress injuries experienced by our clients and consumers, manual wheelchair users. So we've got the wrist, carpal tunnel, elbow, oftentimes we'll have that epicondylitis occur, and then of course the shoulder, the rotator cuff injuries or strains. And research tells us that age and the length of time since injury are correlated with a higher rate of shoulder, elbow, and wrist pain. In this graph from a study by Jordan and colleagues in 2018, you can see a high prevalence of rotator cuff tears in the manual wheelchair riding population. And as you see, after 5 years of manual wheelchair use, 50% of those manual wheelchair riders will develop a rotator cuff tear. And in the population of folks who have been a rider for 20 years or more, that number is an alarming 70%. So of course, there are several factors that contribute to that development of that RSI in the wheelchair riding population. You've got the biomechanics. Of course, we talk about this all the time. We've got different propulsion mechanics. And again, these are things that we in our own prescription process can teach early on. You've got propulsion postures. You've got manual wheelchair fit. Is it too wide? Is it somebody else's? And they're trying to make it work or compensate. And then of course, we already touched on the duration of use. But we also have the wheelchair life that these folks are living outside of that wheelchair, their transfer styles, their MR-ADL routines, their compensatory strategies, overhead reaching, things that we all know. But what happens is that clients are seeing their providers, their physicians or PAs, and they're oftentimes just being offered a cortisone shot to the shoulder and not being referred to a seating specialist. And oftentimes when they are, we're just looking at the configuration of the chair, but not adding 6 visits to look at their transfer style, to teach them a shoulder health program for home, and to try to look at the big picture. So I think everybody can do better. We always have something to learn. But as a whole, we need to make sure that the medical model is broadening our own lens. So what are we spending? These are the direct costs incurred in just this. This is data from a study done by Narvi and colleagues in 2016. And they looked at what is the cost of a rotator cuff repair. So the direct cost just of the OR suite, time, tools, and staff, Medicare was paying roughly $6,367. Other insurers a little bit more. Before you even got to the OR suite, the pre-op therapy visits were between 8 and 12 visits. Post-op therapy visits, an average of about 15, and that's from my local clinical data from our health system. But there's a lot of cost already just to get to that OR suite, diagnostics included. But now you have the indirect costs. So no propulsion of a manual wheelchair for 6 weeks, non-weight bearing transfers, and again, times 4 to 6 months, depending on the person. So they may start weight bearing, but have limitations and struggle. Increased assistance with their ADLs, power wheelchair rental, and now they have to transport it or figure out transportation services, extended time off of work for them or their care team, and then additional caregiver fees. And this is not even including the clients that end up going to a skilled nursing facility temporarily because they don't have that network. So what are we already spending on the indirect costs because we're not using a proactive approach? So it's expensive for all of us. And to really reflect the difference, here we have CRT, that if we could advocate and continue that drumbeat of cost savings with CRT, excuse me, for our clients who use manual wheelchairs and are high risk, we have the K5 with the adjustable rear wheel axle. We have the lightweight material frames that are included in that K5 frame, whether it be a titanium frame, whether it be aluminum and carbon fiber. And then we also have that power assist device, which I already touched on. And I'm just going to go back here. I didn't mean to, but looking at the costs of these devices as opposed to what I just covered, it's a stark difference, clearly. And obviously, power assist, you oftentimes have to rule out why not a group 2 power wheelchair. But again, that goes back to we as clinicians have to really clearly spell out that oftentimes client lifestyles in terms of their home access, their transportation cannot accept a power chair. Their home routines, you have to spell out why their home routines, their transfer surfaces, all of their current routines cannot be readopted or changed to accommodate a power chair. So it's not that it's not possible, it's on us to spell that out. Okay, and another plug here for convincing the funding sources that we all are aware of stewardship and durability, and advocating for a better device is good stewardship of dollars. So looking again at the resident position on the application of ultralight manual wheelchairs, which is now about to release an updated version, which I'm super excited to see. A study that was noted in 2012, I'm sorry, this is from the noted in the position paper, but it's from a different study that is in my resources, and I forgot to put it in on the slide. But that study showed that ultralight manual wheelchairs have been shown to last 13.2 times longer than standard manual chairs, and 4.8 times longer than lightweight chairs. And then also there was a cost comparison about cost to operate. So 3.5 times less cost to operate than a standard chair, and 2.3 times less expensive to operate than a lightweight chair. So they're more durable. They don't test, they don't have the catastrophic failures that came out in the durability studies. And we just need to remind insurance that that is good stewardship. Okay, so looking at the cost of these devices, there is your general Medicare fee-for-service payment of a K5 manual wheelchair, so roughly $2,100, and all the features that it offers, as opposed to the K1 through 4 categories, depending, again, these are a 13-month rental, but these have, again, limitations. So compared to the cost of what we're spending on the surgery and the interventions of an injury, we really need to not hesitate to advocate for this. And this goes right along with the research and best practice guidelines that were noted in the preservation of upper limb function following spinal cord injury by the Spinal Cord Consortium, as well as the wheelchair service provision guide, that we really need to make sure full-time manual wheelchair users are using a fully customizable chair, as light as possible, and durable for continuous use. Okay, pressure injuries. In terms of, this is a study done by Mervis and colleagues in 2019, and they really looked at the data for what we're already spending. So hospital length of stay with a pressure injury was a median of 7 days versus 3 days without, from a study done, by Bauer et al. In 2016. There's a high rate, obviously, with secondary complications once people have these injuries. Pulmonary issues, infection, I think that this audience is very aware, but these complications are also very costly. And that Mervis's study notes that despite increased national attention times 20 years of why this is important and why interventions need to be changed, essentially the prevalence is unchanged while the cost of care continues to increase. So we're all aware, but we need to remind and maybe have insurance take a look at what we haven't changed is we're not being proactive enough. We're being reactive still. So Medicare hasn't paid for hospital-acquired pressure injuries since 2008, and we're spending $11 billion on hospital-acquired pressure injuries. That's $72,000 per hospital stay versus $32,000 without. And I'm sure some folks might already be well-versed in the quality or the QALY. The QALY was developed as an attempt to combine the value of the attributes of cost savings into a single index number. So it looks at quality of life as well as what is being spent. And it's used to quantify that effectiveness of, for instance, a new medicine versus the current one. In other words, the current standard of care is taken as the baseline, and the quality and the QALYs gained from the new or improved intervention are added. And you can see here that a quality improvement of 1.9 life years was noted with prevention. So let's again talk about direct, indirect costs and then add in the intangible costs. So the direct costs is what we're already paying and how outpatient services, wound care interventions, home health nurses to treat that injury or that pressure injury. We're looking at hospitalizations for the debridement, the flap surgeries, for example, and then also the indirect costs of increased caregiver hours, lost wages, etc., prolonged bed rest and increased risk of additional complications, but the intangible costs of the inability to participate in society, the pain, the isolation that occurs with not being able to be up, and the grief. So these are all incredibly important. But the cost of proactive CRT is much, much, much less, and we just need to keep that drumbeat. So we've got multiple seat cushions on the screen that are considered complex and high-end positioning pressure relieving cushions, as well as a bed surface that could be, if we would be able to get a seat at the table and change this, this could be considered the actual value-based option that we should be advocating for. Same thing with power seat functions. These look costly on paper when you're only looking at the MSRP. But when you look at all the data I just covered, these are a drop in the bucket. So you've got your power tilt and elevating leg rest, recline and elevating leg rest, and of course, power standing. And there's a lot of data you can roll into your discussions about how much a person should tilt and recline before you actually get adequate pressure relief. And also looking at the data of micro adjustments throughout the day. Those are both valuable and important to make sure your insurance or funding agencies understand. Here's a great case study that I want to talk about briefly. This is a gentleman named Ignacio, and Ignacio is a former pilot of the United States Air Force. He sustained a spinal cord injury and TBI during a traumatic accident. And during his months in the hospital, he did acquire a significant pressure injury, stage 3. And despite being discharged with a power wheelchair with power tilt, despite his consistent weight shifts for 3 years, and despite consistent wound care interventions, his wound never closed. It limited his sitting time. It limited his ability to participate in his rehab to the extent that he would have and could have without a pressure injury. And it had huge implications for his life. So in his own words, paralysis in general was winning on all fronts. So he would work on his physical training from his bed. He would get up anyways and do what he could for those short period of times he was allowed, but the pressure sore eventually needed a surgical intervention. And as we all know, oftentimes after that flap surgery, there's additional complications that occur. Oftentimes there are folks that dehisce or the wound reopens and you kind of go down that road again. But he decided he was going to approach it from his own proactive model, and he researched standing wheelchair technology. He advocated for standing wheelchair technology, was prescribed and denied multiple times by his insurer. And eventually he was donated a power wheelchair from the Promobile Foundation that he used as his weight shift device, his functional device, his ability to participate in his education. And I'll give you a summary of what he ended up doing. But unfortunately, my point is that insurance didn't pay for this at the time, despite a clear high-risk person, despite a clear limitation in his previous experience with just power tilt. So he went on to attend Georgia Tech. He pursued a degree in biomedical engineering and he graduated with a master's of science in biomedical innovation and development. And he is the Neuro Recovery Executive Director of HINRI Labs in Atlanta, which is focusing on changing the standard of care for spinal cord injury patients. So we may be hearing more from him in the future in our own conference, and I hope soon. And here's just a brief look at MSRP of a group 2 versus a group 3. And again, some group, I'm not trying to just say group 2s can't meet a need. They are a lower cost base, but my point on this slide is that some of our insurance teams, especially here in Oregon, are pushing us to prescribe a group 2 with some limited power seating for complex clients. And so if that's happening in your state, as it's happening here, it's important that we continue to push back. So the group 3 power wheelchairs are, as we said, more modifiable and meet that need. And I did list some MSRPs for what a group 3 is without power seating functions, all the way down to multi. And clearly that's still far less than what we're already spending. Okay, falls we're going to breeze through. Our wheelchair users are a high risk for many reasons, being bone marrow density. They have a common, problem with fractures because of that, as well as soft tissue injuries. And there's a lot of direct costs depending on the site and the extent. So I can't really do a clear cut cost comparison. But oftentimes with fractures, you get the same secondary complications because they're less mobile. Here's a study done by Forslund et al. In 2017 with 149 spinal cord injured patients looking at falls. These are full-time wheelchair riders, and 64% fell, 32% fell recurrently, 34% were injured, and 5% were seriously injured in that time period. If you look at the most common situations, it was during transfers. So now let's look at some simple CRT MSRP numbers of transfer safety features that we can advocate for proactively. So you've got your flip up foot plate on an ultralight, you've got your transfer handle on an armrest. This gentleman is using a ultralight with custom foot plate removal. So he can adequately foot propel with a configured chair that's very easy to propel because of configuration. And as you'll see during his transfers, I guess I flipped this the videos, but there's a video of him transferring where he doesn't have to reach down, he doesn't have to flip up foot plates, and he can use a rigid frame ultralight and do a safe transfer because of that modification. Other examples of the same transfer safety concept in the power realm would be your power seat elevate and active reach. For transfer safety. You can look at transfer handles. This gentleman has 2 little transfer handles that he can use using his tenodesis grasp to kind of scoot himself back and actually, weight bear when he's doing depression style transfers. And then posterior tilt for stability during use. I always advocate for this when clients are really active in the community and they want to be posteriorly tilted so that they're stable while they're just flying down that sidewalk. Okay, other ideas to think about and advocate for are, again, power seat elevate for transfers as well, or access, so clients aren't reaching out of their safe balance point. Retractable joystick, seating setup for managing tone. Here's a gentleman using a standing power wheelchair to manage his tone, hopefully to improve his transfers. And then, of course, sometimes not getting out of the chair at all. You know, going to the medical provider and having your exams in full tilt, full recline, power seat elevating, because they can't get onto a transfer table, or going to get their, you know, this gentleman's getting a shave, getting your hair done, different functional tasks.
Catherine, to interrupt you quickly, there are 15 minutes left in our session, and there's only 2 questions, so if, continue on, and I'll stop you again at 10 minutes.
Oh, perfect. Good. I'm almost done. Okay, good. So application of practice is back to that conversation in the United States. Currently, there are going to be limitations on what is covered under somebody's plan. But again, proactive prescription is already happening. So the VA system uses a more proactive approach than standard insurance. Also in Canada, the VA system, the vocational rehab programs in the states, in each state, the workman's compensation programs, if a worker is injured on the job, pediatrics, pediatric state school programs. And we just need to remember that clients, you know, we're already using this model that clients might be able to access more than we think, that we need to have the conversation and figure out the funding after. So work to be done to wrap up is that it is important that we all are adopting a service delivery model that looks at multiple visits as needed to get the job done, however many is needed to get the job done. CRT deliveries with the clinician ideally, and if they're in between settings, I loved how this was advocated for yesterday during one of the talks, is that maybe they discharge rehab to home health and they're getting their fitting done there, and the home health clinician might be a little bit green. The outpatient seating clinic might be able to telehealth in and use that as a mentorship for home health, and at the same time start to make the connection for the client that there's a home health or a seating clinic that is available when they're ready for their next interventions or checkups. So that service delivery model is really important to use. Another way to foster best practice is really don't take a denial, or make sure your client knows that if they do get a denial, it's not the end of the road. That does happen. Sometimes it's just that more information is needed. Sometimes it's that, you know, what that clinical data unfortunately needs to be reiterated. So just instruct the clients, if they get a denial, to please let you know, and let the supplier let them know that you want to know, and bring them back in to go through the documentation, remeasure what they ask about, or restate what you need. Education and training. We need to make sure that we're not just doing an evaluation and discharging. We need to be part of the training clinically for this complex equipment, because propulsion patterns, programming of a power chair, how they use a power assist device is not easy and intuitive just when a technician is dropping the chair off. So we need, as clinicians, to own that and to make that part of your plan of care, or bringing them back. And then also we need, again, to foster those insurance team partnerships and make sure that they see us as an ally, that we include them when we think about education, and that we participate in their rules advisory committees. And again, if anybody wants more information on that, please contact me to help make sure their rules are updated. I can't tell you how many states need a little buff up from my cursory look. So it's not hard to do. It's just a commitment of some time, but they're not the enemy. We need to look at them and gain their trust, but also push back if we're being if they're also not doing due diligence. Okay, this is a great time for me to put a plug in for a great opportunity to participate in advocacy in a very easy way. The Item Coalition is a coalition devoted to raising awareness and building support for policies that will enhance access to assistive devices, technologies, and related services for people with disabilities and chronic conditions. They led an effort to approach CMS to have a review of their position on power seat elevate and power standing devices. So they put a lot of work into this. They submitted a paper and a request for a review. And this is just from an NCART January update. They still haven't, we're still waiting for the next step in this process, but at some point they are going to open up a 30-day public comment period. And it's essential when they do that, and I'm going to try to blast it out to everybody, but keep your eyes out because it's going to be everywhere. When they do that, all of us need to get on and make sure that our voices are heard, why it's important, why power seat elevate, power standing is important for our consumers, is a cost savings CRT, and why it needs to be included in the coverage guidelines for Medicare clients, because other insurance usually take Medicare guidelines and adopt those as well. So this is a great opportunity coming, and please, please, please keep your eyes out for that. These are the resources I mentioned earlier that are under the tab. The wheelchair handbook is I think a great resource. This was written by a team at Permobile, and I was lucky enough to participate, and it's for consumers. So many things are geared towards clinical education. This is a handbook for consumers to empower them about what equipment is, what it does, how it may benefit them, so that they come into the evaluation more prepared. So this is available on our website. The person can get on and get a free copy sent to them, but it's really important to have in your clinic lobbies to make sure that clients get a copy and are aware of it, because it's information about funding, it's information about equipment benefits, and the client will come in with more understanding of what their needs are. Also, that alternative funding resource is listed and in the chat. So it's just a cursory, smattering of funding options when people need to seek alternative funding. In summary, complex rehab equipment is critical for reducing disablement and improving outcomes. Proactive complex rehab technology prescription aligns with value-based healthcare approach. Not using proactive CRT approach is far more expensive to the consumer and healthcare system than the current reactive model. And we just need to show this by tracking outcomes. And participation and advocacy is the responsibility of all stakeholders. So we just all need to get in the game. And that's what I have for everybody today. So I want to thank you. Here's my contact if anybody has any questions or wants further resources. I'd be super happy to connect. So you want to cover any questions?
Yeah. So first, Trisha Garvin was just commenting that her husband, who's a fiercely independent manual wheelchair user, had rotator cuff surgery, and the emotional costs of losing that independence for his 6 months of non-weight bearing was tremendous. So she was just agreeing with you there, and something that I think insurance doesn't think about. So I'm glad that you discussed that today. Someone else mentioned that they're working with a coalition in Virginia that's aimed at getting Medicaid recipients who live in nursing facilities access to CRT. Currently, that's not covered in their state. They're in legislative session now with a bill, an associated budget amendment. She was wondering if she could share this presentation with the Appropriations Committee.
I do have, I'd be happy to co-present with you, or I do have a handout of the slides. I can't give the presentation, but slides, but I'd be happy to help in any way. Please email me and we can work on that.
I can't see whose name it is. So the person who asked that question, if you would just contact Catherine here at this information listed, that would be the best way to gain access to her. Are there any other questions but from anyone that they'd like to ask in the chat? Does it look like it? Catherine,
Okay.
thank you so much for your presentation, for taking the time to share all of those things with us. I think it's very impactful for our practice. So the chat is blowing up with lots of thank yous if you want to take a peek.
Oh, well, thank you for everybody's time at the end of the day. So I really appreciate it, and reach out if you have any input or connection that you want to make.
Perfect.
And thanks for having me, Julie.
I'm going to put the CEU code in the chat, but I'll also state it verbally. It is 5D8WRX. Just a reminder to fill out your survey in order to get the CEU codes after the course. Thanks, everyone. Catherine, thank you again.
Yeah, happy to be here. Take care, you guys.